I asked AI, what does the future look like for me? And this is what I got. And so it's a very in-depth look at the future. So a couple of things of note for me. X-ray gets moved off to the side on the shelf. We don't need that anymore. We have 10,000 cables coming out of a patient. And we've figured out how to integrate testicular ultrasound and EKGs into what I do on a daily basis. So we'll see. I'm not going to be presenting a whole lot on that data today, but well, here are some disclosures. Not a political slide, but why is this up here? Because we've talked a lot. Everybody's already talked too much about the stuff that I do that I know works, right? So we talked about ablation. We'll touch on it. They've mentioned PVE, hepatic venous deprivation, things that get you to surgery. What we're talking about is the future. So what do we not know so much about yet? And where are we hoping to see the field go? So we're going to be touching a little bit on colorectal, but where we're going to be bringing in other things that might apply to colorectal liver metastases as well. And so I'll leave it up to everybody to decide how much this is, SpaceX satellites already orbiting our Earth versus colonizing Mars in terms of where we think we are on the spectrum of these treatments. So we'll start with Y90. We've heard some about it already today. Briefly, this is a small bead. That's what you see on that slide on the right, microns in size, that has a beta emitting form of radiation on it, which is Y90. That's the radiation that's attached to it. These beads, and I'll show this in a second, are implanted through the hepatic artery. They float out through the bloodstream to the tumors. When they get stuck onto the tumors, they emit local radiation on the order of 2 to 10 millimeters away. And you can deliver extremely high doses of radiation locally using this therapy. So why does this therapy work? My pictures aren't as nice as Dr. Singh's, but in a normal liver, this is how I think about it very simplistically. That purple, bluish color is the portal vein. It delivers most of the normal blood flow to the liver. And the hepatic artery in red delivers very little blood flow to a normal healthy liver. When we get a tumor in the liver, things are flipped. The tumors in the liver get most of their blood supply from the artery, and therefore by delivering medication through the artery, you get it concentrated in the tumors. This is the principle behind hepatic arterial infusion pumps that we've heard about and behind intra-arterial therapies. So where is this most studied and most known? It was done and most studied in the HCC. And just to give a little spectrum of where we used to be with this was maybe about 5 or 6 years ago. How we looked at it, this is a staging system for HCC. And what's happened over time is that treatment has gotten way more complex. And this has gotten so much more complex because treatments have gotten so much better. And this is analogous, I think, also to colorectal, where our systemic therapies, which you see down on the right, have exploded over the last 5 to 10 years. But also, what we've seen over the last couple of years is in HCC that we've moved these arterial treatments up. And why have we moved them up? Because they used to be thought of as these palliative treatments, as mentioned earlier, where we're delivering radiation to downstage tumors. We're trying to give patients survival advantages, but we're not curing anybody with these. However, what we've now seen is that there are certain situations where if we can deliver a targeted large enough dose of therapy, we can achieve more curative results. So where have we seen this already? So this has been studied again in HCC. And what we are now seeing is that, and this is a multi-center study, it was a single-arm study that was done in over 160 patients. They were looking at tumors that were greater than 8 centimeters in size, so very large tumors. Now, just to give a standard for people in the audience, the dosing recommendations typically when we were treating the whole liver was about 120 gray. So these tumors were getting well over that, so 4 times that amount about. So the median dose was 410, but the range of doses was actually much higher than that. And what they saw is when you could give selective doses to these very large tumors, you were getting response rates of nearly 90%. You were getting very long survival rates. So this is again in the HCC population without any surgery. You had an 8 centimeter tumor, you had a 3-year survival of 84%. So it's relatively unheard of. And then what is even more interesting is that they saw that when you were able to downstage these patients to surgery, which again we've heard a lot about today in the colorectal range or discussion, you're getting 93% survival to these patients. So these were very good results. So people started experimenting, where is this limit and how can we prove how effective this is as a curative therapy? So these are 2 studies that were just published recently, and I don't want to go into all of the data, but just to give a little sense of it, These were both looking at small populations, and what they did in these is they looked at these very high dose treatments that were done. So on the right, that first study was looking at a D95 of 719, which is essentially saying that basically all of the tumor got at least over 700 gray of radiation. And a similar on the other side. And what they saw is that when you actually went to go transplant these patients, again, we're talking about putting together some of the talks earlier already, we're talking about HCC here, when you transplanted these patients, they had in one study more than 87%, in the other study 76% complete pathologic necrosis. So that's curative, right? We've taken the organ out, we've studied it, there is no tumor left after this. So what does this actually look like in real life? This is a very large tumor in the right lobe of the liver. We place a catheter, again, into the hepatic artery. This is what that diagram showed earlier. You can see as we inject it, there's this dominant flow into the tumor. There's very little flow to the normal liver. If we deliver the high dose treatment in this fashion, then 1 year later we can see a complete response still there. So this is where I think the role, if we want to extrapolate where we want to start to think about Y90 in the future for colorectal, we want to start thinking about it in kinds of these terms. Are there tumors that really aren't immediate resection candidates? Maybe we're trying to bridge somebody to a liver transplant like we do for HCC that we've talked about today. Can we start to employ some of these same techniques, these same concepts, to bring people closer to a curative approach? So now I'm going to be moving on. So that's, I think, stuff that we're doing today. Now we're going to start talking about things that are maybe more on the spectrum, moving towards colonizing Mars kind of thing. So the concept here is somewhere in between what I just described and what we talk about with hepatic arterial infusion pumps. So we're not delivering radiation, but what if we can deliver chemotherapy and target it in extremely high doses to the liver, and do it in a non-surgical fashion. So hepatic arterial pumps still require a major operation. What if we can do the same concept but do it without a major operation? So this is a device that's now approved for melanoma liver metastases, ocular melanoma. But essentially what the concept is here is that we are isolating the liver as its own perfused organ. And we do this in a couple of stages. The first thing that you do is you place a catheter into the IVC, so the major veins, that collects all the blood from the liver. The hepatic veins typically dump into the IVC right inside the liver. And if you can blow up a balloon, I'll show you another real-life picture of this in a second, you can isolate all the blood that's flowing out of the liver. You can then, in the same fashion as we showed with Y90, place a catheter into the artery and deliver chemotherapy into the artery. Then, as that chemotherapy perfuses through the liver, it will drain out through the veins, and instead of going back systemically, what it will do is be collected into this catheter that's sitting in the veins, go through a filtration system, and then get re-delivered back into the body, like a bypass, like you would if you're putting somebody on cardiac bypass. So this is what it would look like in real life. You see the pictures at the top, you have a catheter in the artery, and you're seeing these small tumors in the liver that are enhancing. If we just delivered chemotherapy in this fashion, it would go in, it would bathe the tumors in chemo, and then it would get absorbed systemically, and you'd have an incredibly high dose of systemic chemotherapy being delivered. But instead, what it's doing is on the right there, you're collecting that blood. You see it's not flowing anywhere, it's sitting in the liver. It's getting drained out into this pump, filtered, and then only once the chemo is out, getting placed back into the patient's body. When this was studied in melanoma, it was recently approved. This was the study that was done. Typically, just so you know, patients with this type of melanoma who have liver metastases on average had a survival of about 12 months. There were 91 patients in this multi-center study that were put in. That's the dose. It was a single arm open label study. And what they saw is that PFS went up to 9 months, and from that 12-month median overall survival went up to 20.5 months. So again, not colorectal here, but in this very, very fatal disease, you were seeing very incredible response rates and incredible survival for this population. So again, future we'll see whether this will be applicable to colorectal, but again, very promising idea. Now we're going to move on to something a little bit different, a little bit further away. So we've talked a lot about so far about tumors that get a lot of blood supply from the hepatic artery. Right? And what this diagram here is showing us is as we deliver the treatment or blood cells, they're going to preferentially go to that tumor. That's great because we're going to preferentially get all our treatments to where we want them to be. However, if you have a tumor that has very little vascular supply, and this can be true of many colorectal tumors as well as we think about pancreatic tumors, which I'll show in a second, they tend not to be as enhancing. So if you see something light up on a CT or an MRI, that's because it has a lot of blood flow going to it. If they don't enhance and they look dark, they often have less blood flow going to them. The problem is not only that you get little flow to the tumor, but you also get a lot of flow to the liver. So now you're delivering your therapy not really ideally, you're not concentrating it where it needs to go. So the concept here is to change that dynamic. So what can be done in this situation is that this is again a catheter that's going into the artery, just like I've shown a couple of times already. But instead the catheter is now blowing up balloons on either side of where the tumor is sitting. We're now not relying on actually the blood flow to deliver the therapy into the tumor anymore. What we're doing is by blowing up those balloons, we're dropping the pressure in that segment of the artery down to nearly zero, right? Nothing's coming in, nothing's going out, the pressure is very low. We can then hook up this catheter to an infusion pump at a very high pressure, and that's what you see on that right hand of the slide. As you start the infusion, the pressure in the artery starts going up as you're pushing against a brick wall because that balloon is blown up. And the therapy, the chemotherapy, actually diffuses across the arterial wall. So it's not delivering an arterial therapy in the way we've always thought about it, but actually just using this as a road to get near where you want to treat. In this situation, chemotherapy diffuses right across into the tumor. So again, not studied in colorectal yet, but we have started looking at this with pancreatic cancer, which I said is, again, one of these tumors that doesn't have a lot of arterial flow to it. This is a study that is still ongoing, but some interim data was just presented, which I'll show you. And this is a study looking, again, at pancreatic cancer where patients were treated with standard of care chemotherapy up front. They got essentially standard of care radiation after that and then got more chemotherapy. Then the patients were randomized to either continue just on chemotherapy. These are patients who can't be resected, so they're basically going to be on chemotherapy for life at this point, which unfortunately can be quite toxic and cause quite a few side effects. Or they get randomized to receiving this intra-arterial therapy. So again, we're just delivering local chemotherapy, no systemic therapy to go along with it. So what did it show in this again, interim data so far? So what we would hope and expect is that actually the side effect profile was much, much better. Patients aren't getting systemic therapy, therefore they're not getting a lot of systemic toxicities that are related to it. So you see on that right-hand side, the intra-arterial gemcitabine group had significantly lower toxicities pretty much across the board, with the exception of what you would expect from a procedure, which is a little bit of pain, a little bit of nausea immediately during and after the procedure. What was also interesting at this interim analysis only is that they're already starting to see a survival advantage. So obviously we're going to have to see this all the way out to see if this holds. But if this holds and we're seeing a survival advantage in a different toxicity profile, we might be looking at a complete paradigm shift when it comes to treating pancreatic cancer. And then the question we will then pose is this true elsewhere? Can we deliver the same therapy? Will the chemotherapy, again, diffuse to areas that we couldn't used to get therapy in the same fashion in other organs and with other disease types? This was mentioned already, but I think if you're talking about the future, I think we have to at least take a little step for where we are right now when it comes to ablation. So we've long been arguing in my camp that ablation is as effective as resection for multiple different diseases. We finally have randomized phase 3 studies demonstrating that for colorectal in specific, percutaneous ablation, and it can also be done intraoperatively, but ablation, burning a tumor, and this is typically done nowadays with microwave ablation, burning a tumor is as effective as cutting out a tumor. So this is a study that was mentioned earlier today already, published just this couple months ago in Lancet. 341 patients, fewer than 10 tumors, so still quite a bit of burden of disease. Tumors, again, have to remain small. Ablation is not good for very large tumors. But what we did not see is any difference in overall survival, any difference in disease-free survival. And we saw mortality as improved with ablation and adverse events being improved with the ablation side as well. So again, I think we know now, this is not a future, that ablation should be competing in many patients with surgery for curative treatment. But where is the future of ablation going? I think what's very interesting, and obviously there's been some talks and presentations about this already here, but what other than thermal ablation might be the future for ablative modalities? And so histotripsy is just one of the many things that is being looked at, but I think it bears some discussion here. And so for people who aren't familiar with this already, what histotripsy is a completely non-invasive ablation modality. Typically, most of the modalities that I use today are some thermal-based thing. We're putting a needle into a patient, we're turning the machine on, it is either burning tumor or freezing tumor, and that's true, I think, for many of the fields that are presenting here today. What histotrypsy does, however, is use ultrasound beams to target tissue in the body without completely non-invasive fashion. By focusing those ultrasound beams down, you actually can disrupt the membranes of the cells themselves and cause essentially instantaneous cell death. And what you're seeing here is both a histopathological slide showing that, as well as a phantom that's actually showing those red blood cells being destroyed in a model. Now, what's, I think, interesting, in addition to the non-ablative, non-invasive nature of histotrypsy, is also this potential for preserving support structures, right? So again, if it's a very cellular thing and you destroy the cells will die. However, if it's more of a collagen matrix that you're dealing with, whether that might be a nerve structure or, in the case of liver, bile ducts or blood vessels, then it's possible that, thermal techniques don't really care which one you're doing. If you burn something, whatever's there is going to get burnt. However, if this can target only viable tumor cells and viable liver cells, then you can have these support structures stay behind. So this is just an example in a patient where there was a bile duct and a blood vessel that was going right through a tumor. The patient was treated with histotrypsy, and you can see both on path as well as on the MRI that the support structures, the blood vessel, the bile duct, are actually still intact after the treatment. So where has this been studied so far? So again, this was in a mixed cohort of patients, about half with HCC, about half with metastatic disease of all types. This was the trial that was done to get their approval. Patients had 3 tumors, 3 centimeters in size, and they were mostly looking at technical success and safety. And again, what you see on the right there is just some pictures of how the procedure is done using ultrasound to target these tumors. And what they were able to say in this study so far is that there was a technical success in nearly all patients. They were able to treat the area they wanted to treat. At 30 days, they saw an efficacy of seeing an ablation zone where they wanted to create one, and a really good side effect profile. So again, relatively low complication rates, and really the only liver injury that was seen in this study was possibly related to disease progression. So again, a very interesting, and we're going to see where this goes again. Will it replace? Will it be an adjunctive tool? I think is still up for decision. And that is all I was going to be presenting on today. So thank you very much.